Welcome back to the deep dive. Today's going to be a little different.
Yes, it is.
Usually we take a topic and, we just wander through it, letting our curiosity lead the way. But today, we're on a mission.
We are absolutely on a mission.
We are shifting gears from broad exploration to high-stakes preparation.
That's right. For the next 40 minutes or so, I want you, the listener, to completely shift your mindset. You are no longer just a casual observer.
Okay.
Imagine you are a postgraduate resident. You are sitting in the hot seat. You're prepping for your MD anesthesiology exams, perhaps for a rigorous board like Gujarat University. And I am sitting across the table from you.
And you aren't just my co-host today. You're the external examiner.
I am. And I'm not here to make small talk. I'm here to see if you can handle one of the most complex multi-system challenges we face in the operating room.
Right.
I want to see if you can synthesize physiology, pharmacology, and crisis management into a passing grade, or better yet, a gold medal answer.
The topic on the table is a heavy hitter: Parkinson's disease and anesthetic considerations, with a special reference to general anesthesia and awake craniotomy.
It's a mouthful, but it's a classic exam topic for a reason. It forces you to demonstrate that you understand the brain, the airway, the heart, and, all the drugs we use to control them.
And our sources for this are the big ones.
The absolute heavyweights. We've pulled from Miller's anesthesia, Stolting's coexisting disease, Morgan and Mikhail, and specific clinical case guidelines from experts like Dr. Kaushik Jothanath and Dr. Puneet Khanna.
So the mission is to synthesize all of this into a structured, high-scoring, 20-mark answer.
Exactly.
We're going to break this down exactly how you would write it on the exam paper. Part A, the general management of Parkinson's disease.
And then Part B, the specific, very high-yield scenario of general anesthesia versus awake craniotomy.
Let's do it.
Let's begin Part A.
Section 1, Introduction and Exam Framing. Professor, if I open my exam paper and see this question, how do I start? What's the first sentence?
You start with a crisp, authoritative definition. You write, Parkinson's disease, or PD, is a progressive neurodegenerative clinical syndrome.
Okay.
And it's characterized by a specific tetrad. You need to list these four.
Tremor, rigidity, bradykinesia, and postural instability.
Perfect.
Historically, I've heard it called shaking palsy. Is that worth mentioning?
Or a paralysis agitans. Yes. Mentioning those historical terms shows you've done your reading, but you need to stick to that clinical definition for your core marks.
Okay, so why is this so relevant to us? Why is this such an exam favorite?
Well, you said it. It's not just about a shaking hand.
It's a multi-system trap.
That is the perfect phrase for it. If you treat PD as a simple movement disorder, you will fail the case. You'll fail the exam.
Because it involves the airway.
The airway dysphagia and aspiration risk. Huge. It involves the autonomic nervous system orthostatic hypotension. It involves the mind, dementia, and depression.
And we're seeing more and more of these patients.
Yeah. Critically, with an aging population, you will see these patients for everything. They come for cataracts, they come for hip fractures, and they come for complex neurosurgery, like deep brain stimulation.
So the examiners love it because it tests everything at once. What are the common question patterns we might see?
You'll see three main types. First, the short note, maybe 5 marks. Anesthetic implications of anti-Parkinsonian drugs.
Okay, very specific.
Second, the long answer, the big 20 marker. Perioperative management of a patient with Parkinson's disease for, say, an abdominal surgery.
And the Viva.
And third, the Viva voice trap. Tell me about the drug interactions between MAO inhibitors and opioids. We will cover all of these.
All right, let's move to Section 2. Pathophysiology. This is marked as very high yield. We need to understand the mechanics of the breakdown.
You absolutely do. You cannot manage the patient if you don't understand the basal ganglia. The core pathology is the degeneration of dopaminergic neurons.
In a very specific place.
In the substantia nigra pars compacta.
Pars compacta. That's one of those phrases you have to get right.
It is. It's a specific region of the midbrain that projects to the striatum, the caudate, and putamen. In a healthy brain, the basal ganglia acts like a complex transmission system for movement.
Like a gearbox.
A good analogy.
Yeah.
And it relies on a delicate balance between two neurotransmitters.
The accelerator and the brake.
That's the best way to visualize it. You have dopamine, which is generally inhibitory for muscle tone. It keeps movements fluid and loose. It releases the brake.
And on the other side?
You have acetylcholine, or acepi, which is excitatory. It increases tone. It's the accelerator. In a healthy person, these two balance perfectly.
But in Parkinson's, the dopamine factory shuts down.
Correct. The Substantia Nigra cells die off, so the brake release is gone. But the accelerator, the acetylcholine, is still firing away at full speed.
So you have an unchecked excitatory system.
And that cholinergic overactivity is what leads to the rigidity and the tremors. That's the key imbalance.
Is there a histological feature we should mention? Something to, show with the pathology textbook?
Yes, absolutely. Lewy bodies.
Lewy bodies.
These are eosinophilic inclusion bodies found inside the dying neurons. They contain a protein called alpha-synuclein. If you write Lewy bodies containing alpha-synuclein in your answer, the examiner knows you understand this at a cellular level, not just the symptoms.
And this degeneration isn't just motor, right? It spreads.
Sadly, yes. It affects the locus coeruleus and the dorsal vagal nucleus.
And that explains the non-motor features.
It does. It explains the depression, the sleep disorders, and the autonomic dysfunction, which is, frankly, the anesthetist's nightmare.
Okay, let's unpack those symptoms in Section 3. Clinical features relevant to anesthesia. We have the classic mnemonic trahep tremor, rigidity, akinesia, postural instability. Let's break them down for the anesthetist. Start with the tremor.
Okay, so the tremor. It's a resting tremor. This is crucial for differentiation in the recovery room. It is usually slow, maybe 3 to 6 cycles per second.
The pill-rolling tremor.
That's the one.
Why does resting matter to us in the OR or PCU?
Because it disappears with intentional movement, and critically, it disappears during sleep or under general anesthesia.
Oh, okay.
So if a patient is waking up in the recovery room and shaking violently, you need to ask, is this their Parkinson's tremor coming back?
Or is it post-anesthetic shivering?
Or a rigor from a drug reaction? Knowing that the PD tremor is a resting tremor helps you distinguish.
And we have rigidity.
Lead pipe, or cogwheel rigidity. Lead pipe is a constant resistance to movement. Cogwheel is the tremor superimposed on that rigidity, so it feels like a ratchet.
And for us, that means?
For us, rigidity means increased muscle tone, which means increased metabolic cost. These patients burn more oxygen just lying there. Their baseline oxygen consumption is higher.
What about bradykinesia or akinesia?
This is the difficulty initiating movement. It's often the most disabling symptom for the patient. But let's talk about the features that will kill the patient on your table.
The airway.
The airway.
The mask face isn't just cosmetic, is it?
Not at all. It's a sign of deeper problems. Patients with PD often have pharyngeal dysfunction. They have dysphagia, difficulty swallowing, and coeluria.
Excessive drooling.
Yes.
That sounds like a dangerous combination.
It is lethal. You have a patient who produces too much saliva and cannot swallow it effectively. That is a massive, massive risk for pulmonary aspiration.
So that's the #1 risk.
If you get a Viva question asking, why is this patient high risk? Your first answer should not be the tremor. It should be aspiration and impaired airway reflexes.
And the respiratory muscles themselves, are they affected?
They can be rigid, too. You get restrictive lung disease patterns because the chest wall just doesn't expand well. They have a weak cough, so they can't clear secretions post-op. It's a perfect storm for pneumonia.
Okay, and finally, autonomic instability. We see this phrase a lot. What does it actually look like in the OR?
It looks like a roller coaster. These patients have orthostatic hypotension, thermoregulatory issues, urinary retention.
So they're hemodynamically labile.
Extremely. If you push a standard induction dose of Propofol, their blood pressure can absolutely crash because they lack the sympathetic reflexes to vasoconstrict and compensate. They are fragile.
Extremely fragile. Let's move to Section 4, antiparkinsonian drugs and anesthetic implications. This is marked exam core. This is where the pharmacology knowledge needs to shine.
You cannot pass this case without mastering the drugs. The absolute mainstay of treatment is Levodopa.
Why Levodopa? Why not just give dopamine?
Because dopamine is too polar. It does not cross the blood-brain barrier. It's locked out of the brain.
Right.
Levodopa is a precursor that can cross. Once inside the brain, an enzyme called dopa decarboxylase converts it into dopamine.
But we always see it combined with something, right? Carbidopa.
Yes, and you need to know why. If you gave Levodopa alone, about 95% of it would be converted to dopamine in the gut and blood before it ever reached the brain,
causing all sorts of side effects.
Massive systemic side effects, nausea, vomiting, arrhythmias. Carbidopa is a peripheral decarboxylase inhibitor. It acts like a bodyguard. It prevents conversion in the body so that more of the levodopa can get to the brain where it's needed.
Okay, here is the golden rule question for the exam. The patient is fasting for surgery. NPO. Do they take their levodopa?
Yes. Write this in capital letters in your answer. Never stop the levodopa.
Never. Why is it so critical?
Because the half-life is incredibly short. only 60 to 90 minutes.
That is very short.
It is. If you skip even 1 or 2 doses, plasma levels hit zero fast. This can precipitate acute dopamine depletion.
And that leads to
Severe rigidity, akinesia, the so-called locked-in state, or even a neuroleptic malignant syndrome-like picture with hyperthermia and autonomic collapse. It can be fatal.
So even if they are MPO, nil perosin.
Give it with a sip of water right up until they come to the OR. If it's a long surgery, you place an esogastric tube intraoperatively just to give the meds on schedule. You must maintain the levels.
Now let's talk about the trap drugs, the interactions. Specifically, MAO-B inhibitors like Serotonin.
Right. Serotonin prevents dopamine breakdown in the brain, which is good. But there is a classic lethal interaction with the opioid meperidine.
Also known as Pethidine.
Exactly, Pethidine, which is often used for postoperative shivering.
A very common scenario.
If you give Pethidine to a patient on Serotonin, you risk serotonin syndrome. We're talking hyperthermia, agitation, rigidity, coma. It's a medical emergency.
So Pethidine is absolutely contraindicated.
Absolute contraindication. If the surgeon asks for it, you say no and you explain why.
What else is on the do not give list?
Anything that is a dopamine antagonist. I mean, think about it. The patient is already dopamine depleted. The last thing you want to do is block the few receptors they have that are still working.
Okay, so what drugs are those?
The big ones are antiemetics. Avoid metoclopramide, which is Reglan. Avoid prochlorperazine, promethazine. And avoid butyrophenones like haloperidol and droperidol.
So if they're nauseous post-op, what do we use instead?
Ondansetron is your first choice. It's a serotonin antagonist, totally safe. Domperidone is also an option because it doesn't cross the blood-brain barrier. But never, ever metoclopramide.
Let's move to section 5. Preoperative evaluation. We're in the clinic with the patient. What are we looking for?
You are playing detective. First, the medication history. What are they taking? What's the dosage? And exactly when was the last dose? You need to write this down.
Number 1, meds.
Second, the airway. You have to ask specifically about swallowing difficulties, choking on food, recurrent chest infections, and drooling. This tells you their true aspiration risk.
So you're actively looking for signs of dysphagia.
You are. Third, the autonomic status. Check their blood pressure lying down and then after they stand up. If there's a significant drop, they have orthostatic hypotension, and you know they are going to be incredibly sensitive to your induction agents.
Moving to section 6, intraoperative management. We're in the OR. What's the big decision? General anesthesia versus regional.
The textbook answer is regional is often preferred if possible.
Why is that?
It avoids the polypharmacy of GA, it avoids airway manipulation, and it lets the patient continue their meds orally. But there's catch.
The tremor.
The tremor. If a patient has a violent tremor or significant rigidity, performing a spinal or epidural is technically very difficult, if not impossible.
Right, you can't have them moving.
And you might need to sedate them to do it, but sedation in a patient with a compromised airway is risky. It's a judgment call.
Okay, so let's say we have to do general anesthesia. What agents do we choose?
For induction, Propofol is preferred. It's been shown to have some anti-tremor effects upon emergence, which is a nice bonus.
What should we avoid?
Avoid thiopental if you can. Some older data suggests it may suppress dopamine release. For maintenance, sevoflurane or isoflurane are fine. Avoid halothane as it sensitizes the heart to catecholamines in a patient who may already have arrhythmias.
What about ketamine?
Avoid ketamine. Write that down. It stimulates the sympathetic nervous system. In a patient who is already autonomically unstable, it can cause severe hypertension and tachycardia. It's just too unpredictable.
And muscle relaxants. Any controversies there?
Yes, a very important one for your exam, Succinylcholine.
Okay.
Experts like Dr. Jothanath have flagged this. These patients are often immobilized or have some degree of muscle wasting, which can cause an upregulation of extrajunctional acetylcholine receptors.
Which means a risk of hyperkalemia if you give suxes.
A potentially life-threatening hyperkalemic response. So it's not an absolute contraindication in every textbook, but for the exam, the safer answer is avoid succinylcholine.
So what do we use instead?
Use Rocuronium or Vecuronium, an intermediate-acting non-depolarizer, and of course, monitor the neuromuscular junction very closely with a nerve stimulator.
Section 7. Postoperative considerations. We've successfully extubated, the surgery is over. What are our main priorities now?
Priority 1, 2, and 3 is immediate resumption of their medications.
Say it again?
Get the dopamine agonists back on board. If they can't swallow, use the NG tube you placed. Do not let them miss a dose.
What else are we watching for?
Aspiration. Keep the head of the bed elevated, have suction ready, and watch for confusion. Postoperative delirium is very common in this group.
And pain management.
Multimodal is the key. Use NSAIDs like ketorolac, use paracetamol, use opioids sparingly.
Why sparingly?
Because they worsen constipation, which is already a problem, and they can depress respiration in a patient with a rigid chest and weak cough. It's a risky combination.
Okay, Professor. That wraps up Part A. I feel like that is the standard of care answer for the general case.
It is.
Now, let's pivot. Let's go for the gold medal. Part B, general anesthesia versus awake craniotomy.
This is where the topic gets really fascinating and where you can really impress an examiner. This usually applies to two main scenarios.
Deep brain stimulation for Parkinson's.
Right. And resection of brain tumors in what we call eloquent areas.
Okay, Section 8, Introduction to Craniotomy Anesthesia. Let's start with the basic question. Why would we ever keep a patient awake while we are opening their skull?
It's a great question. The answer is functional preservation. Meaning, if a tumor is sitting right in Broca's area, the speech center, or the motor strip that controls their right hand, you cannot trust anatomy alone. The brain shifts, maps are variable.
So you need real-time feedback.
You need the patient to speak, to count, to move their hand, while the surgeon stimulates the brain with an electrode. It's the only way to distinguish the tumor from vital functional tissue.
And for Parkinson's specifically, why awake for that?
For DBS, the surgeon is placing an electrode into a tiny microscopic target, usually the subthalamic nucleus, the STN, or the globus pallidus. To find that exact spot, they use microelectrode recording, or MER.
They're literally listening to the brain cells.
They are listening to the electrical song of the neurons, and they need to see if the patient's symptoms improve.
They need to see if the tremor stops.
Exactly. They turn on the stimulation. If the tremor stops and the rigidity melts away, they know they're in the right spot.
Yeah.
You cannot test that if the patient is asleep and paralyzed under general anesthesia.
Let's briefly touch on Section 9, general anesthesia for craniotomy. If we do put them to sleep, for a different kind of case, what are the main goals?
For GA, remember the 3 C's. Control intracranial pressure, or ICP, maintain cerebral perfusion pressure, or CPP, and cytoreduction.
Cytoreduction.
Brain relaxation. You want a slack brain so the surgeon has room to work without retracting and damaging tissue. GA gives you total control of all these things.
So the advantage is control. Secure airway, control of CO2 through hyperventilation, and the patient is completely immobile.
Exactly. The limitation, of course, is that you lose all functional testing.
So Section 10, awake craniotomy, the exam favorite. Let's nail down the indications.
2 big ones. 1, tumors in the eloquent cortex, so speech, motor, sensory areas. 2, functional neurosurgery, which primarily means DBS for Parkinson's or other movement disorders, and some epilepsy surgeries.
Who's a good candidate for this? You can't do this on everyone, surely.
Not at all. Patient selection is absolutely key to success. You need a cooperative, calm, motivated patient.
What's a contraindication? Who would you say no to?
Someone who is confused, very anxious, or claustrophobic. Anyone with a difficult airway or severe obstructive sleep apnea, that's a huge risk. And you generally can't do it for posterior fossa lesions because of the positioning.
Section 11, techniques of awake craniotomy. How do we actually do it? What are the options?
There are 2 main flavors, 2 main techniques. The first is called asleep awake asleep, or AAA.
Asleep awake asleep.
You put the patient to sleep with a general anesthetic, usually with an LMA or a nasal mask, for the painful parts.
Like putting the head in the pin frame in the initial incision?
Exactly. Then once the bone flap is up, you turn everything off and you wake them up for the mapping part. When the mapping is done, you put them back to sleep for the closure.
And the second method?
The second is monitored anesthesia care, or MSC. The patient is sedated but breathing on their own throughout the whole procedure. This requires a much more cooperative patient.
Regardless of the method, the cornerstone has to be pain control. The scalp block.
This is vital. You cannot do this procedure without an excellent scalp block. For your exam, you must know the anatomy. We block 6 nerves bilaterally.
Okay, let's walk through it. I want to visualize the head. Where do we start?
Start at the front, above the eyebrows. You have the supraorbital nerve and the supratrochlear nerve.
Suborbital and supratrochlear. Got it.
They're both branches of the first division of the trigeminal nerve, V1. You block them at the supraorbital notch.
Okay, moving laterally to the temple.
There you have the zygomaticotemporal nerve, a branch of V2, and the auriculotemporal nerve, a branch of V3, which runs just in front of the tragus of the ear.
Zygomaticotemporal and auriculotemporal. 4 down, and the back of the head.
At the back, you block the lesser occipital nerve, which comes from the cervical plexus, and the greater occipital nerve from C2, which you find midway between the mastoid and the occipital protuberance.
So 6 nerves bilaterally. If you get a perfect block, do you even need much sedation?
Very little. And that brings us to section 12, the critical part. Anesthetic goals and the interference.
Right. We talked about microelectrode recording, the MER. The surgeon is listening to the brain cells fire.
Yes. And this creates a major conflict for the anesthetist. Most of our sedative drugs, Propofol, benzodiazepines, work on GABA receptors.
And GABA is inhibitory.
GABA is inhibitory. It suppresses neuronal firing. So if you give too much Propofol, the subthalamic nucleus, the target, it goes quiet. It becomes invisible to the surgeon's microelectrode.
On top of that, the drugs would abolish the tremor you're trying to test for.
Precisely. So for DBS surgery, the rules we learned in Part A get flipped completely upside down.
How so?
In Part A, for general surgery, we said never stop the meds. For DBS surgery, we often S-stop P the anti-Parkinsonian meds on the morning of surgery.
We deliberately stop them. Why?
Because we want the patient to be symptomatic. We want the tremor to be present so we can prove intraoperatively that the electrode stimulation stops it. And during the case, we have to minimize or stop our GABAergic drugs during the recording phase.
So what do we use for sedation if propofol and benzos interfere?
Dexmedetomidine.
Ah, Dexmed.
Wow. It is the hero drug of awake craniotomy. It's an alpha-2 agonist. It provides sedation and some analgesia without causing significant respiratory depression, and crucially, it has minimal effect on the microelectrode recordings. It keeps the patient calm without silencing the brain.
Section 13. Complications. What's the nightmare scenario? What can go wrong?
The number one intraoperative complication you need to be ready for is seizures.
From the cortical stimulation?
Yes. The surgeon is stimulating the cortex, and that can trigger a generalized seizure.
What's the treatment for that right there on the table?
First, tell the surgeon to stop stimulating and to irrigate the brain with cold saline immediately. That's usually enough, but you must have a small bolus of propofol or midazolam drawn up and ready to abort the seizure if saline fails.
And the airway. That must be a constant worry.
It is. The patient's head is pinned in a Mayfield clamp. They are completely covered by sterile drapes. You have zero access. If they obstruct their airway or have an apneic spell from oversedation, you are in a major crisis.
It's why patient selection is so important.
Critical. You cannot afford to have an airway emergency in that situation.
Okay, section 14, comparison. This is a classic exam question. You're asked to draw a table comparing GA versus awake craniotomy. Let's build that table verbally.
Let's do it. For the exam, draw 3 columns. Feature general anesthesia, awake craniotomy.
Okay, row 1, airway.
For GA, it's secure, you have an endotracheal tube. For awake, it's at risk or shared.
Row 2, ITP control.
For GA, it's excellent. You can hyperventilate. You use agents that reduce brain metabolism. For awake, it's variable. If the patient coughs or gets agitated, their ICP will shoot up and you'll get a tight brain.
Row 3, neurological monitoring.
For GA, it's purely electronic EEG, evoked potentials. For awake, it's clinical. It's the patient talking to you, moving their hand.
And the most important row, row 4, the outcome.
For awake, the major advantage is it allows for maximal tumor resection with minimal functional deficit. That's the whole point. It improves outcomes.
Section 16 now. Let's do some common exam questions and Viva traps. I'm going to throw some rapid-fire scenarios at you. You're the candidate.
I'm ready. Hit me.
Trap 1. The surgeon asks for 25 milligrams of Pethidine for shivering in a Parkinson's patient in recovery. What do you do?
My first action is to check if the patient is on any MAO-B inhibitors, like Serotonin. If they are, Pethidine is absolutely contraindicated due to the risk of serotonin syndrome. I would use a forced air warming blanket instead and explain my reasoning.
Good. Trap 2. The patient is nauseous. The nurse hands you a syringe of metoclopramide.
I would politely refuse it. Metoclopramide is a dopamine antagonist and will worsen the patient's Parkinsonism. I would request ondansetron instead.
Trap 3. The Viva examiner asks, should you stop Levodopa before a routine laparoscopic cholecystectomy?
No. For non-DBS surgery, the medication must be continued perioperatively without interruption. The last dose should be given with a sip of water, and it should be resumed immediately post-op via an oral or NG route if necessary.
Trap 4. The same examiner then asks, okay, what about for deep brain stimulation surgery?
For DBS, yes, the Levodopa and other anti-Parkinsonian medications are typically held on the morning of surgery. This is done deliberately to unmask the tremor and rigidity for accurate intraoperative testing of electrode placement.
Perfect distinction. Trap 5. Succinylcholine use in a patient with long-standing rigid Parkinson's.
It should be avoided if possible. Due to the risk of immobility and muscle changes, there is a theoretical but serious risk of a hyperkalemic response from upregulation of extrajunctional receptors. Rocuronium, with careful monitoring, is the safer choice.
Excellent. Section 17. Diagrams. If you're writing this answer out in the exam, what do you draw to get those extra marks?
They draw 3 simple things. They don't have to be artistic masterpieces.
Okay.
Number 1, a very simple schematic of the basal ganglia loops showing the balance between the direct and indirect pathways and where dopamine fits in.
Okay.
Number 2, draw the side of a face and mark the 6 landmarks for the scalp block nerves. That's a huge win.
And 3.
Just draw the GA versus weight comparison table we just discussed. Visuals break up the text and show the examiner you can organize your thoughts clearly.
Finally, Section 18. Summary and exam conclusion. How do we wrap up this 20-mark answer? Give us a model conclusion.
You conclude with a powerful synthesis. You state that Parkinson's is a complex, multi-system disorder that requires a delicate, thoughtful, anesthetic balance.
And what's our role in that?
The anesthetist is the guardian of the dopamine-acetylcholine balance.
I like that.
And our goals are threefold. 1, prevent aspiration by managing the airway. 2, maintain hemodynamic stability in the face of autonomic dysfunction. And 3, facilitate functional preservation, either by resuming their meds promptly or by using advanced techniques like awake craniotomy.
And the final sentence.
A sentence like, ultimately, a deep understanding of the underlying pathophysiology is the key to safe and successful perioperative management of these challenging patients.
That is a masterclass.
That is how you pass the exam.
Listener, your homework from the professor is to get a piece of paper and draw those scalp block landmarks right now. Good luck with your studies.
You know more than you think you do. Stay calm. Think physiology first. Good luck.
We'll see you on the next deep dive. Stay curious.